So welcome to the to an introductory training on the integrated care pilot that's being conducted in Victoria. It's 2021. I am Del Maxwell. I'm the project lead for the integrated care pilot that involves your 11 organisations from all around Melbourne. This introductory pilot or this introductory training will be conducted by Ken Minkoff and from Zia Partners, and I'll introduce Ken in just a moment. I'm the project manager and I'll be supporting you guys together with Jen Thompson, who's our implementation consultant over the 12-month journey. So should you have any questions about this or need any support, please, you'll have a lot to do with us, but please feel free to reach out, and we will put my contact details up on the screen in just a moment. Every organisation that is involved in this, each of the 11 organisations, you will have your own project leads that will be in charge of implementing the integrated care pilot, or the comprehensive continuous integrated system of care that we're about to roll out today. And we will be working with you to help you to do that, together with a group of willing change agents that you will recruit over the course of this journey. So we're very much looking forward to getting started. And now I'm going to hand over to Ken, who is one of the architects of this model. Ken, welcome to our training.
Yeah, well, thank you so much, Del. And Del has been gracious enough, as you may see in the slide, to offer both her email address and her mobile number, so that if for whatever reason, after we do this initial orientation to the project for all of you, if you have questions and you're not sure who your project lead is in your organization, or you get excited about this and want to know more, please just reach out directly to Del. She's incredibly able and efficient, and she is going to keep all the parts moving in the right direction so this is successful. So I'm very excited to be able to do this video for the purpose of helping everyone who is participating in this exciting project across all of the 11 organizational partners to understand what this project is trying to achieve and what it has to do with improving and inspiring the care that all of you are delivering to people with all kinds of challenges every single day. And this project is something that has been connected to the mental health and addictions transformation that has been engendered through the work of the Royal Commission in Victoria. There has been a lot of recommendation about the importance of creating an integrated delivery system to help people who have co-occurring mental health and substance conditions and other kinds of complex challenges in their lives. And there's a lot of planning and discussion that's been going on at high levels in various forums around the state for this purpose. But this particular pilot is the single place within Victoria where there are a group of organizations sharing responsibility for a particular geography southeast of Melbourne that are working together to actually create a demonstration of what an inspired integrated system could look like. And we have launched this project with state funding earlier this calendar year. And now we are kind of moving it into operation. Each organization has made a commitment to participate in the project, to identify a project lead, a team of change agents or champions, and to provide explanation and orientation to all staff, and to get everybody involved in thinking about what is it we're going to do to improve our ability to deliver services to the people who are coming in the door, both within our organization and inside the organizational partnership in the region. And so what I want to do is kind of explain the framework that's being used to guide this process. Hopefully it's something that will be exciting for you guys. And it's built on work that we, meaning Zia Partners, which is myself and my partner, Dr. Chris Klein, we're both psychiatrists, that we've been working on in Victoria and actually in other parts of Australia as well for many years. And that has actually been piloted in certain organizations in Victoria. And Jen Thompson, who's the project consultant, has had great success doing this. But this is the first opportunity to take this to scale. Now, what we do for a living, Zia Partners really is just the two of us, and we're based in the United States and in Tucson, Arizona. But we've been working together for several decades, doing what we modestly call changing the world. And what that means is that our major work is providing consultation to large systems, state systems, local or regional systems, complex organizations, small organizations, all over the English-speaking world, to help those systems transform themselves at every level, to be about the needs and hopes and dreams of the people and families with all kinds of co-occurring conditions and complex challenges that are regularly showing up. And this kind of work has lots of fancy jargony names. People call it system transformation. They call it integrated systems, children's systems of care, recovery-oriented systems, trauma-informed systems, et cetera, et cetera. What it boils down to is how do we organize our whole system to be about the people who need help? And the biggest driver for doing this in systems all over the place, including yours, are of course the people themselves. As you know, people are showing up at the door of the delivery system every single day with all kinds of desperation and complexity, and encountering systems and structures and rules and paperwork and bureaucracies and requirements that make it feel like the job of getting help when you're desperate and suffering from complicated issues is going to be really, really hard. Not only do the people we serve experience this, so do we. Most of us went into this business not because we thought this was a cool way to become a millionaire, but because we had the weird idea that we wanted to be about helping people. And we too go to work inside the big system, and we too find ourselves quickly immersed in the same rules and requirements and bureaucracies and structures and struggles that make it feel like our mission and values of helping the desperate people in front of us is also going to be really hard. And what we're starting to figure out, and what we, meaning Chris and I, have been working on for decades, is that we're starting to realize that we're not going to get where we need to go simply by trying to fund a few special programs or hire a few special people to work around what often feels like a dysfunctional system. What we need to be thinking about is how do we organize everything we do with every resource that we have to be about the needs and hopes of the people that we're serving and the values that got us into this in the first place. And when we're talking about everything, we are talking about everything in the system being organized to be about the people we're serving. Every process, every program, every policy, procedure, every practice, every piece of paperwork, every person providing help with every penny that we have has to be aligned with our values and with what people actually need and want. Now, when we start these, so what's happening in this system is what's called the integrated care pilot. As Del was mentioning, it's focused on the St. Kilda region broadly. And it's looking at a model for this one population where there are multiple different types of service providers that all share an overlapping geography. And there are 11 partners who do different things, big providers, smaller providers, doing different kinds of mental health and substance services and housing services and primary care and all that. And there's an organized approach that everybody is agreeing to work in to create a shared vision for what's supposed to happen, and then a process for getting there. So when we start these conversations and when we describe the way this whole approach works, we start by purposefully putting people in the middle of the conversation, that we know the system in general, and certainly your system in Victoria, has not been historically well designed to serve. And we call this the complexity challenge. And what the complexity challenge means is that systems tend to be organized into various silos and pockets. There's mental health professional services and, as you know, alcohol and drug services, and there's health services and, you know, different kinds of buckets of service. And then there are people who have needs that overlap all the different service buckets and often have a great deal of difficulty figuring out where and how to get connected to what they need. And this becomes the complexity challenge. So in each of these system conversations, let's start, if we're designing the system to be about people, let's start with people that we know the system probably hasn't been well designed to serve. And you can start with any pair of issues that may create a challenge. In this particular instance, given the driver of the Royal Commission and the priority of this particular combination of issues inside the mental health and addictions services in Victoria, the starting complexity challenge are people who have overlapping mental health and alcohol, drug, other kinds of addictive issues. And we often call these people with co-occurring conditions or sometimes co-occurring disorders. Now let's talk about who are we talking about here? Well, we're talking about any person of any age with any combination of any mental health issue, including trauma, and any substance or addictive issue, including gambling or even nicotine dependence, whether or not they've actually already been diagnosed. We also talk about co-occurring families, which are particularly important if you're working with children, because they always bring their families with them, but they're important broadly in other contexts as well, where one member might have one kind of problem, like a child with an emotional disturbance or an intellectual or developmental disability, and another member of the problem has another kind of problem. Another member of the family has another kind of problem, like a family member or caregiver with a substance use issue, so that the family system needs an integrated approach. Now, why do we start a system change discussion by looking at this particular group of people? Well, first of all, these folks are everywhere in the delivery system across the 11 organizations. Okay, these folks are in mental health settings, they're in adult and child mental health settings, they're in substance settings, they're in housing settings and homeless settings and settings operated by all our cool human service partners like the criminal justice system and homeless shelters and so forth and so on. In addition, whatever issues you start with, these folks automatically start to bring in others. In other words, these folks, as you know, because you work with them, don't just have mental health and substance issues. They have medical issues, housing issues, legal issues, parenting issues, disability issues, financial issues, cognitive and learning issues, et cetera, cultural and linguistic issues, and so on and so on and so on. These are folks who are characterized by complexity. And the next thing we realize pretty quickly, rocket scientists that we all are, is the more complex your issues are in our system, the worse you're likely to be doing. So these are the folks in our scarce resource system who are having the poorest outcomes and the highest costs in multiple domains. And their poor outcomes are in every conceivable arena. These are folks who are more likely to relapse and be rehospitalized. They're more likely to be labeled treatment resistant and non-compliant. They're more likely to engage in self-destructive, suicidal, aggressive, or violent behavior. They're more likely to be victims of trauma or perpetrators of trauma or both. They're more likely to be getting in trouble in other systems and costing money in other systems. They're more likely to have significant medical and health issues. And most tragically, particularly among adults, these are the folks who are most likely to die and to die prematurely. And, and so one of the things that we would be thinking about is if our job is to design our system to be about the people who need us, naturally we would be thinking that our current system in Victoria at every level would be designed so that people and families with co-occurring mental health and substance issues and other complex needs would be specifically prioritized for help throughout the delivery system. But what we've experienced, unfortunately, is in most of the system, at most levels of the system, it's just the opposite. These folks are not experienced as priorities. In fact, they're often experienced as misfits. At the systems level, these are folks who have often dared to have more than one problem in systems that have been designed and funded and regulated historically, as if everybody had one kind of problem only or only one kind of problem at a time. Programs have often been similarly designed. So those of us working with real people in real programs may constantly be experiencing a need to contort our clients to fit our programs or contort our program to fit our clients, which is a skill that I call creative sociopathy. And those of us who do it regularly, and I'm sure many of you do, get to be so good at it that we forget that it's bizarre that we're working in a system where we're supposed to be doing that every single day. These folks are often experienced as misfits at the level of the people providing direct help. Most folks are trained to think of themselves as being either a mental health person or a substance person or a housing person or whatever, but not both, not all of the above. So when we encounter people with complex needs, we immediately experience a misfit between what they need and what we know. And of course, they experience this as well, feeling, oh my goodness, here's another person acting like they're not quite sure what to do with me. Not only are these folks experienced as misfits, we often wind up experiencing them negatively. As we might gather from the poor outcome data, these are folks who are very crisis prone. They often show up in different places in the system in states of great disarray. And, they often have a great deal of difficulty fitting into the service boxes that would make it easy for us to know how to help them. They often have a great deal of difficulty following all the beautiful instructions that we would like to give them so that they can achieve the beautiful outcomes that we would like them to have. And as a result of this, they may stir up feelings in us. And the feelings often include feelings of helplessness and hopelessness and despair and frustration, irritation, and even rage. And they often acquire labels that we may reserve for people who make us feel that way in the system. They become the antisocial, manipulative, borderline, med-seeking, non-compliant sociopaths. And we're often introduced to them by our colleagues before we've ever met them. Guess who's back? And guess what? You're going to have to deal with them this time. So these folks who are having the poorest outcomes and the highest cost are not only not prioritized for care, they're often folks that we have been programmed in one way or another to be holding at arm's length. So one of the starting places for thinking about how to transform the entire system is to say, what if we create a system in which all the parts of the system are designed to welcome people with co-occurring mental health and substance issues and other complex needs exactly as they are, wherever and whenever they show up. And then the next challenge is, what are we welcoming them into? So we're not welcoming them into paperwork. We're not welcoming them into a referral somewhere else. We're welcoming them into hope. And that's the second major challenge, what we call the hope challenge. And part of the core of this process is to understand that hope is the thing that helps all of us, and especially people who are experiencing many challenges, to have the energy to see the possibility of a future that is meaningful, and to have the energy to do the work to address all of their challenges to make progress toward that goal. So for that reason, we have to recognize that people and families with co-occurring issues are vulnerable easily, as you all know, to losing hope. And for that reason, in order for our system to be about the people who need us with multiple serious challenges, we need to be in the hope business. Now, when I say being in the hope business, I'm getting at one of the fundamental aspects of what this whole change process and the integrated care pilot is about. I'm not talking about we need to be hopeful people, because I know you all are in your hearts. But when I'm talking about being in the hope business, I'm talking about how organizational processes at all levels of the system create the capacity for us to deliver the products to our customers, the people that we're serving, that are the most important. And in our business, we often lose track of how we have to have a business process that's directly connected to core values like welcoming and hope, rather than the production of billable service units or other markers of, what we do that are disconnected from the result we're producing for the people that are coming in the door. So we need to be in the hope business, especially for the people who have co-occurring issues and other complex needs, because they're the people that are hardest to inspire, because on one level or another, they're often experienced as misfits. And yet they're the people who need the inspiration the most. One of the things that got my partner and I started in this is that back 20 some odd years ago, she was the medical director of the behavioral health system in the state of New Mexico in the United States. And one of the things that she was tasked to do in her job by her boss, the commissioner, was she was told, Dr. Klein, I want you to go and find out what it's like in the state of New Mexico for people having met us, meeting our system. And Chris said, okay, that sounds like a good idea. Where do you want me to go? And her boss said, I want you to go sit on the State Medical Mortality Review Committee, which is essentially a committee of doctors and lawyers sitting and reviewing all of the people attached to the state delivery system who had died. And when they were sitting there looking at these stories of people who had died in their service system, and they got away from the idea that they're supposed to, find someone else to blame and not themselves, and instead look at what are the patterns that contribute to people dying prematurely in our services. They started looking at things that, some of which we know much better now than we did 20 some odd years ago, but are still striking. So if you had co-occurring mental health and substance issues, you died earlier and at higher rates than people with a single problem of either type, who died earlier and at higher rates than people in the general population with no problem at all. And they died of many things. they died of suicide, and they died of homicide, and they died of mysterious accidents. Mostly, however, people died of common medical conditions, and they died much earlier than they should have. And they died not because there was no medical care available, but because they weren't participating in the care that was available to do the things that would have prolonged their lives. And then when they looked even further, they found a pattern, and we found this pattern all over in systems. And the pattern they found was that many of the people were dying, a disproportionate number, were dying within, mostly of medical conditions, within 4 to 6 weeks of having knocked on one of the behavioral health system doors. And they couldn't understand this, from looking at the charts and the records, it made no sense. So they put down the charts and they started calling the family members and loved ones of the people who died and said, look, when your person with co-occurring needs came to our door, what happened that led them to die 4 to 6 weeks later? And in one way or another, in lots of different languages and cultures and words, people basically said the same thing. When our person with complexity came to your door as a system, they came away with less hope than before they went. And it wasn't that they weren't seen, and it wasn't that people were, for the most part, reasonably nice. It's just that the system wasn't designed to welcome and inspire them. The system was designed so that the more complicated you were when you showed up, the more hopeless everybody felt. And so for people who were incredibly vulnerable, whether they were coming on their own or somebody brought them, they were holding on to this flicker that maybe by virtue of having contact with someone would give them additional hope to inspire them to do the things that would help them to take better care of themselves and make progress. And when people are met with the sense that, I don't know, I'd like to help you, but I have no idea what to do, or gee, it's too bad we don't have the resource for you. Oh my goodness, now I have to fill out twice as much paperwork, whatever it is, then people go away with a little bit less hope. And when people go away with a little bit less hope, they make a fewer good decisions and a few more bad decisions. And as you know, because you work with these folks, there are a subgroup of all the people we work with that are so close to the edge in their lives that a few weeks of bad decisions will kill them. There are many, many more people that we work with that when they lose a little hope, they don't die. Things just get worse. And they, stop their medication, or they relapse with substances, or they do something, they hit their kids, they commit crimes, they lose a little, and back they go cycling through the system. So we need to be in the hope business. And to do that, we have to make hope a priority, because hope is something that we can provide unconditionally. We have to be careful for ourselves, which is why we need the organizational support, not to make hope conditional, like I will be hopeful for you if you happen to have the issues I know how to fix. I will be hopeful for you if I happen to have the perfect resource to send you, and like that. And having done this for a long time, I know even as an official expert in this area, the odds that I will know exactly how to fix the next person I meet are really small. And the odds that I will have a perfect resource for anybody are even smaller. But what I do know is that when people show up, I know that by virtue of an encounter, my job is to create a partnership in which that person feels more hopeful and less alone, especially when neither of us have any idea exactly how to fix the situation. So hope business means every person, every family, especially those with the greatest number of challenges, are inspired when they meet us with hope, that we can help them with all their issues so that they can make progress to achieving a happy, hopeful, productive, and meaningful life. Now, we start thinking organizationally, how effective is our system? How effective are organizations? How effective are our programs in welcoming people with complexity, in inspiring hope, and then moving on from there? And there's another reason this whole issue becomes important when we're thinking about redesigning systems. Because when we're talking about the population of people with co-occurring mental health and substance issues and other complex needs, not only are these folks likely to be doing poorly, there are lots of them. So the prevalence of co-occurringness is so great that we say co-occurring or complexity is an expectation, not an exception, everywhere we look in our delivery system. And again, it's not that we don't know this, we do. You guys live this every day. What's striking is the degree to which our service system has been designed with limited resources, as if this weren't true. So we have these folks with co-occurring issues, and we are trying to put them in services that are primarily designed to address single problems, maybe with a little sprinkling of something else. All the while, we're wishing for new pots of money to deal with the weirdos. And they're not the weirdos, they're the normal people. And we're never going to get enough new money to deal with them all. Neither are we going to be successful if our approach is that every person with two problems needs two clinicians, two programs, two funding streams, two service buckets, so that we can go broker than we already are. What we need to be doing is to build the capacity to welcome the needs, inspire the hopes, and address the concerns of people and families with complexity inside everything we do, so that all services are designed with the idea that the next person we're seeing will be co-occurring. And then when people show up and they only have a few problems, yay, much simpler. All services are designed to welcome, engage, and provide integrated services to individuals and families with all kinds of complex issues, starting with mental health and substance co-occurring. So this is the framework that we're thinking about as we go into like applying this to this subset of the Victoria State delivery system. And this gets us into thinking, okay, we're going to do this in a system. What's a system? So the system is not just what happens at the state level, at the ministry level. It's not, and this is very important, it's really hard for folks to wrap their heads around. You can't deliver integrated services by merging a couple of departments in the ministry or changing everybody's portfolio or simply rewriting some memos from above or putting all the money into a single pot. That often creates more distress and disjunction than not. Because what every system is, just like the system in Victoria, is like systems within systems sitting next to other systems, like a set of nesting Russian dolls. And you know what this is like because you work in it. Okay, and each agency that you work in is a subsystem of a larger system. Each program is a subsystem. Each team or unit in the program is a subsystem. And each one of these systems has several different funding streams and masters and requirements and so forth that they have to respond to. So how do we do transformation in that kind of a system? Well, it means that we want to build on what we already have, but to have all the parts of the system operating in a common process to achieve a common vision that is about the people that we're serving, with every dollar spent, every policy, procedure, and practice. For the state, that means the whole state ministry, all the subparts are operating in a common vision within whatever their scope is. And for those of you that are in service provider agencies, it means the agency as a whole, every program and every person delivering care is working toward a common vision as well. So this leads us to the framework that Del mentioned at the beginning that we're using to guide the integrated care pilot in Victoria. And it's called the Comprehensive Continuous Integrated System of Care, CCISC, which is the last thing in the world you have to remember. Okay? but what it means and what the vision is important. So basically where it starts is that every program is a co-occurring program. Whatever it is you're doing, you're in the co-occurring business. Why is that? Because co-occurring people are already there. They're an expectation in your services. So to say it a little bit longer and more jargony, every program in the system becomes welcoming, hopeful, strength-based, recovery or resiliency-oriented, if you like those terms, trauma-informed, culturally fluent, and co-occurring or complexity capable. But basically every program is a co-occurring program operating on the highest principles of inspiration for the people that are served. Now within that, every program has a different job, because each program is designed with a different purpose and has different subsets of people who come in your door, bringing their co-occurringness along with them. So every program has to get really good at doing its job with the assumption that the people at the other end of its job are not people with one problem, but people with multiple issues. So that has to be built into the design. Not only every program is a co-occurring program, so is every person providing help. Everybody becomes a co-occurring helper. And again, that means welcoming, hopeful, strength-based, trauma-informed, culturally fluent, co-occurring, or complexity capable. That's part of everybody's job. And we call this a recovery process for systems. And we have a 12-step program of recovery for systems. And we use that language because what's really behind this is a lot of application of fairly sophisticated organizational change technology to help systems move across multiple organizations and multiple levels to literally embed a vision and value-driven services for people with complex challenges into every fiber of their being. But most of you are never going to be whiz-bang experts in organizational change theory, but you do know something about what individual people go through on their recovery journey and how individual people who start being very complicated and challenged and discombobulated, just like our service system can often be, can engage in a recovery program and step by step over time transform themselves. Well, the same thing can happen for organizations and systems if people follow the path in the same organized way, step by step. So what does it mean for an organization to be co-occurring or complexity capable? It means you think about your program. And for the moment, that's all you need to think about. If you're listening to this, think about your program. And think about if back in the way I say it is this, if back in the beginning of time when my program was first invented, if we knew then what we know now about the co-occurringness and the complexity of the people that we are serving, and if we knew then what is known now, which is some of what I'm going to be sharing with you today, about how we can organize ourselves within our existing mission and resources to be regularly helpful to those people with their complex needs inside what we do, how would we have organized our program? Every policy, every procedure, every piece of paperwork, every piece of practice, so that those of us who are doing the work have all the support that we need to be routinely delivering the best, most successful interventions for those folks and having the most fun, helping them inside the partnerships that we create inside of our work. So it says every program organizes itself within its mission. Is it an adult mental health program for people with serious mental illness? Is it a residential alcohol and drug treatment program for people, for pregnant and parenting women, let's say? Is it a homeless outreach program? Is it a primary care program working with people who come in with lots and lots of health and mental health and substance use issues? Is it a school-based outreach program for kids who are having all kinds of trouble in the school setting? I mean, it could be anything. But is it organized so that whatever it starts out to be, it's designed to be about the complexity of the people who are there, the issues, the complex issues that they have. And we have tools for that we'll be using in this process. All of you will be involved, or hopefully not all of you, but almost all of you will be involved in one way or another doing a program self-assessment tool that's designed for mental health and or alcohol and drug programs called the Compass EZ, which helps a program to look at itself and as a team and say, so how well organized are we on the assumption that what we're doing is being in the co-occurring business? And how can we label the stuff that we're doing well? And where do we find things that we can improve within our own resources that'll help us do a better job for the people we're trying to serve? And every program or agency will have its own 12 steps of improvement. And everybody is going to be doing their 12 steps together, kind of like a big 12-step meeting for the entire system. Not only programs, every person providing quote unquote clinical care. And clinical doesn't mean you have a license of some sort. It means you're trying to help people who have lots of challenges. So it includes everybody starting, from physicians, peer supporters, everybody in between. Everybody is helped inside their job at their level of training to have the instructions and skills and competencies to know how to be a helpful, hopeful partner to people with multiple issues who are no doubt already sitting in their quote unquote caseload. And this, again, it doesn't mean you have to go out and get extra licenses or degrees. This applies whether you have 1 degree, 2 degrees, 6 degrees, or none. You're a cool peer supporter doing homeless outreach. You're the person working the Saturday night overnight shift in the residential substance program when all the people are trading their psych meds and being really weird. You're the person working the Saturday night overnight shift in the psychiatric inpatient unit when everybody's sitting around comparing where the best marijuana in all of Victoria can be found, bought, grown, whatever. Everybody is helped inside their job to have the tools they need to be helpful and hopeful with the folks that are sitting in front of them. And there are tools for staff as well that we may be using in this process. We may not. They're there if people want them. We do have 12 steps for staff so people can kind of take a look at where they are and everybody can work together to figure out what are the next things I want to do. But the key to this doesn't start with training people. It starts with building organizational context and instructions and supports. So good helpers who are already good helpers know how to use their existing skills to do better with the people in front of them. So is this your vision? Well, I hope so. But most people say, well, it sounds kind of cool, but really, can you really do stuff like this? How do you get there? How do you do this? So the good news is, for this pilot, is we do know how to do this. And I don't mean by we meaning me, although it's nice because Jen Thompson, who's the project consultant, has actually done this in different settings in Australia quite ambitiously, and it's been wonderful. And we've done this in all kinds of systems in the US. But the bigger point is that we collectively already have the knowledge to do this. The hard part is applying it to the point that we actually change what we do every day. So there's two kinds of knowledge. One is clinical knowledge, meaning knowledge about how to help people. And the other part is organizational knowledge, which is knowledge about how to transform systems and organizations. And the key to each of these is that there are some fairly simple things that folks need to do. But just because they're simple doesn't mean they're easy. They're actually quite hard, because one of the things you know from the system, because you work in it, is how much inertia the system has, where just like clients often do the same things over and over again that don't work and they keep expecting different results, so do our systems. They're bureaucracies which have embedded practices that are not helpful, but they're so embedded, they're very hard to change, even though the stuff that would work better is a lot simpler and easier. That's our collective task. Okay? So the first piece of this is that we know something about how to help people with complex needs, and it's not as complicated as we often make it out to be. Back in the late 90s, I was asked by SAMHSA, which is the Federal Substance Abuse and Mental Health Services Administration in the United States, to chair an expert panel whose job was actually to design best practices for systems working with people with co-occurring mental health and substance use disorders. And we all worked together, and we were, the thing they asked us to do was to look at the research, to inform what we came up with. But what we did was based on knowing what I'm telling you, which is that co-occurring is an expectation. So we're never going to get where we're going to need to go in a system simply by trying to fund some special programs with extra money that we don't have, knowing that most of the time the people who need the special programs won't want to go to them anyway. We needed to, so we looked at the research, and what we did is we looked inside the research and we asked ourselves this question: inside all the research that is helpful, what is it that they do that's really helpful? And can we look at the practices and interventions that work and think about how we can extract the things that work and embed them into the routine operation of any program? So that's where this started. And then right around the 2000, 2001, Chris hired me to go do this with her in New Mexico. And that's where we did it first. And we developed the whole toolkit. And over time, we did a lot of things that actually cut the death rate in this population in half with very limited resources. And then we learned something about how to make this happen in all kinds of systems. And we've been doing this for quite a while. And one of the main things that we've learned is that over time, the more that we've worked with this, we started with mental health and substance issues. Since then, we've worked with all kinds of other things, homeless stuff and criminal justice stuff and children's systems and people with intellectual and developmental disabilities and all those services. And what we've learned is, first, the more issues that we're dealing with, the simpler everything has to be. And in fact, the more that systems are going to make progress, the more simple everything has to be. And so we've got this down to 6 principles. And each principle has associated interventions that can be done by any cool group of people in any setting, with applied and adapted to their particular population. The other part of simplicity is really the importance of trying to make the work simple and understandable to us and to the people we're serving. One of the things we experience in behavioral health service delivery all over the world is that we've gotten so good at talking to each other in complicated psychobabble jargon that we don't understand ourselves most of the time, let alone the people we're trying to help. So everything about this is part of the challenge, is to see how effectively we can turn what we're doing not only into simple approaches, but to transmit them in simple language and use that as a basis for engaging people at very complicated challenges in their lives. So I'm shortly going to go through the 6 principles so that you can get an introduction to what they are and how they're applied. I'm going to try to connect each one to what would that mean in terms of not only changes in what you do as individuals, but policy, procedure, and practice in your program that would help you to do it more consistently and help everybody on the team to be moving in the same direction. Now, the other thing that we know how to do is we know how to get there organizationally. And so there is something that, from my perspective, knowing about organizations is is a recovery process for systems and organizations. And it's something that most of you have heard about anyway. It's called continuous quality improvement, or a little bit more specifically, customer-oriented continuous quality improvement, which is about how do we continuously improve organizational processes in a data-driven, specific methodology. It's not random, to improve the experiences and the outcomes for our customers, which applies to any kind of industry or business or whatever, including behavioral health, amazingly enough. And there are things, and this is what we're talking about here, is every organization, every program gets to set up its own continuous quality improvement process to look at what it's doing for its customers with co-occurring needs and to apply this stuff to improve their experiences within the resources that are available. So in order to do this, it requires a bit of shift of organizational culture as well. Continuous quality improvement is a partnership. It requires a partnership that's both horizontal, and starting in this integrated care pilot, all the 11 organizations, although they're all different sizes and shapes, are equal partners. But it's also a vertical partnership. So inside an organization, it's not only horizontal, all the programs and divisions of the organization, but it's also a vertical partnership. Good recovery-oriented continuous quality improvement requires a partnership between senior managers, middle managers, team leaders and supervisors, and people who are delivering service on the front line, as well as people with lived experience and people who are people who are receiving services. And that requires a piece of structured teamwork that has to be fit the nature of the particular program that's involved in it. And inside each program goes through a process of their own 12-step program to figure out how to look at what they're currently doing, see what they're doing well, find areas where they can apply the principles to improve what they're doing, and get better results for the people that are being served within each organization. And then all the 11 organizations work together as partners to figure out where there are gaps and where they can all help each other to fill those gaps. So everybody's sharing responsibility for the complex needs of the whole population in the St. Kilda region. Within this, part of what makes this exciting is that each organization has the opportunity to identify people representing the voice and experience of the front line who become empowered as change agents in this process. Change agent become part of a change agent team within the organization and then across all 11 organizations, which will be coordinated by Jen Thompson and supported by us. And the point of the change agent team is to work in partnership with each other and with leadership to overthrow the established order of the system to create a new vision. And if this kind of thing gets you excited, then you probably may be naturally wired to be a change agent. Think about raising your hand when the opportunity comes along, because this is going to be a lot of fun. So within this, just in any recovery process, everybody's making small steps over time. But if everybody makes small steps across an entire system in the region, then the whole system actually starts to shift a lot. And the key to this is that it's not just a project where people learn new things and do things for a while. Part of what the change is not like you just learn new things, that the changes are embedded in new policies, procedures, instructions, practice supports. So that if everybody leaves and new people come on, they inherit a new set of instructions that helps them to do things that are more aligned with what people actually want and need. And the key thing to welcome everybody into this organizational improvement partnership is to think of it as a big recovery process for the system, like a big 12-step meeting, and everybody's welcome to participate, provided that everybody shows up inside the serenity prayer of system change. The serenity to accept the things you cannot change, which is everybody else. The courage to change the things you can. Your own work, your own team, your own program, your own agency, your own span of control, wherever you happen to be, and the wisdom to know the difference. And everybody gets together and starts focusing on making the changes. in their span, according to a common vision, as I said earlier, even if everybody starts only by changing a little bit, the whole system starts to change quite a lot. So there are a lot of different design components, which I'm not going to get into here, that all can be embedded within this as we go forward. And then there are a lot of potential partners who may be included in this process, within the 11 organizations. A lot of these things are already included. But I don't want to kind of get off into the high level stuff. I want to keep focused on what does this have to do inside the work of people on the front line. And we start by doing this by looking at the 6 principles. So here's the first principle. Okay, simple. Co-occurring or complexity is an expectation. We want to build that expectation in a welcoming manner into everything we do. Now, the key to this is that welcoming is not just a nice idea, and it's not just about people being nice. I know you're all nice and you're all as welcoming as you can be. Welcoming is about an organized process and structured practice that we're all familiar with. It's called customer service. And if you're familiar with customer service training, if you've had customer training, service training in other industries, then you know that this is a formal piece of organizational technology where people are provided specific instructions and supports for knowing how to welcome and engage not just the easy customers that fit neatly, but particularly the challenging customers who may be experienced as difficult or misfits. And the thing about this in this process is not that we're necessarily going to wind up doing this as well as a hotel chain like Hilton or a big department store or Walmart, which is a big thing in the US. It's so much that in the behavioral health world, historically, we haven't paid that much attention to this formally at all. And we're in a business where whether or not people get welcomed and engaged, particularly when they have many challenges, it's not just about whether they purchase our toiletries or stay at our hotel. It's a matter of life and death. So we start with things like basic welcoming. Hi there. You know, you're one of those folks who've got lots of challenges. You know, when you come in here, it looks like you might be hearing voices. And it smells like you maybe had a couple of drinks to get up the nerve to show up here today. And it says on the paper that you have lots of medical issues. In fact, it looks like you're having trouble walking. Your family wants nothing to do with you. You've just lost your housing and you're in trouble with the law. You know, you're the kind of person we most love to be engaging here because you're the person who's likely to be having the hardest time. We know it couldn't have been easy for you to show up here today. Thank you for coming. You're in the right place. We're really, really glad you're here. We know our business when we meet you is not to perfect you, control you, manage you, refer you, et cetera. Our job is to get to know you, inspire you with hope, and help you figure out how to get connected to us, as well as anyone else we might find along the way to help you with all your issues so you can have a happy, hopeful, beautiful life. Now, there's nothing in that speech that's rocket science. The question that we ask ourselves is how well organized are we by policy, procedure, and practice so that when people show up exactly like that, everybody in our entire organization knows exactly that that's the kind of thing that we want to say. And not just read it off an index card, although that's helpful if you need to memorize it and learn it, but to say it from the heart, looking people right in the eye. And many organizations say, you know, we have an improvement opportunity. But then we go further. What about intermediate welcoming? What if we have a rule that says we never trash talk about the people we're serving based on their co-occurringness or anything else, even if they're not listening, any more than we would use racial slurs behind people's back? And you know how easy it is when we start to get frustrated because people aren't doing what we want. You know, we start, oh, they're antisocial, manipulative, they're med seeking, they're non-compliant, and then we write it in the chart. And then we're amazed that the people are acting like they don't want to work with us. When how we frame people with our language affects how we experience them and how they experience us. And so what if we had a rule that said we never do that? And we always find ways of talking about people, even when they're not there, in a welcoming manner. And then there's really advanced welcoming. What happens when people show up at our door in ways we wish they didn't, or with symptoms we wish they didn't have? So somebody shows up at the quote unquote alcohol and drug door and they're saying they're suicidal or they're saying they're psychotic. What do we do when someone shows up at the mental health door, or any door for that matter, and they're smelling of alcohol and kind of unsteady on their feet? How do we make it our most important business in that moment to have that person feel really, really happy that when they were in crisis, they happen to have the good sense to show up at the place where people are paid to help them, rather than thinking somehow our job is to tell them that they behaved badly or inappropriately and kick them out of there and hope nothing too terrible happens before they land. So welcoming gets pretty deep pretty quick. And it isn't long before we start finding opportunities to improve our ability to welcome the people, particularly those who feel like they fit us the least, who've managed to show up at our door. And then we start looking at our policies, access barriers, rules. You need to have this length of sobriety before you get that, or you need to not be on that kind of medication before we do this, or whatever. And, where are these rules? We very often have access rules that were written, who knows when, 20 years ago, and they're passed along like legendary, things that can never be challenged. And we have to start paying attention. What does this mean for the people who are showing up? Is this really making any sense anymore? And then the other part of welcoming is welcoming people personally with complexity, but also welcoming the opportunity to really see their issues. Because when people show up at a mental health door, they often feel like nobody really wants to know about their drug and alcohol stuff, or they may actually have had traumatic experiences of being kicked out because they talk too much about it. And vice versa in alcohol and drug settings, and vice versa in housing settings or health settings or whatever. You feel like the smart thing to do is keep your mouth shut so people don't know all the messed upness you have, because they may not want to deal with you then. So part of welcoming is having the opportunity to see, identify, write down, document all the issues that the person brings us so that we can help them more effectively. So you have to be thinking, I work in mental health. If the next person I see tells me that they used methamphetamine on the way in, am I going to let them know how happy I am that they told me and how proud I am that they had the courage to do so? Because welcoming is not just filling out, seeing and screening and documentation is not just filling out forms. It's literally welcoming the ability to identify the issues and documenting them, counting them, so we know how many people actually have co-occurring issues in our data systems routinely. So we use that data to inform what we do. And honestly, if we don't count you routinely, it's because we've organized our system as if you didn't count. Okay, and we see this all over the place. So in New Mexico, as the whole system got better just at welcoming and screening and identifying, that's when the death rate got cut in half. So what are we welcoming people into? Because a lot of times people will say, well, okay, we'll welcome them in if you want us to, and we'll screen them and count them if we have to. But once we've done all that, where the heck do we send them? Which is a clinical model known as welcome and out. And so the key is that we send them to us. So the foundation of success is to create partnerships. And the partnership begins immediately. It's not like you jump through 7 hoops and then if you're lucky, you get somebody who'll sit with you and do something. It's like the minute you're at the door, the more complex your needs are, the more important it is that the partnership begins immediately, because the connection is hard. So how do we build that? Well, and there's a nature of partnership that it all has the following characteristics. In all the best practice programs, the partnership is empathic. We listen to people's stories. It's hopeful, which I'll talk about. It's integrated, and it's strength-based. And every one of those things is not just nice language. It's things that we can build into our practice tools. So remember I said we're in the hope business. So hope has to be purposefully informed. We want to find out from people what is not just their hope for this session, but what is their most hopeful vision for a happy, meaningful, successful life, so that we can inspire them, help them grow that hope, and join them in using that hope to fuel the energy they need to succeed. And we want to write that down in our first meeting. We want to make it important. We want to return to it every time we do a service plan or an update or things get tricky or messy. We want to bring people back to their hope. So it becomes a major piece of content driver throughout their service. Most of us use diagnosis or problem as the main driver. What I'm saying is we want to be in the hope business. Whatever the issues are, let's start by building that person's hope as the foundational piece of documentation. Okay? The relationship is integrated. That means all of us are partners to help people with everything. Okay, we're all in that partnership. Why? Because the person has all these issues all the time. So being a partner means we're in there with you. We may not be experts in everything. We may not be experts in anything. But our job is just to understand what's going on a little bit better than the person so we can help them figure out better what to do, and to be willing to be in there with them, figuring it out and learning with them. That's what great partners do. And we're strength-based. Strength-based is a formal best practice for helping people who have lots of challenges. But to be strength-based, you can't just sprinkle a few nice things and call them strengths on what basically a deficit-based cake. You have to have the whole cake be strength-based. It has to be foundational. And there's lots to this, but there are two fundamental things that help to illustrate it. And then we have like practice tools for doing case presentations and service plans and assessments, all of which kind of emphasize the energy on identifying strengths and successes as foundational. So the two rules, the two simple things are, most of the people we work with have lots of ups and downs in their life around their issues. And we tend to give them this little piece of jargon. We call them chronic relapsers or recidivists, which is very hope uninspiring and deficit-based. But in the land of strength-based, there's no such thing as a chronic relapser. There's only people like all of us who are recurrently successful. And the thing that's really interesting, important, and fascinating is not that people who have lots of issues do poorly from time to time. It's that they're able to make progress. They're able, even for a short period of time, a few days, a few weeks, a few months, to do something well that helps them to improve. And that takes enormous strength. And when we meet people, we want to learn as much as we can about what they did right, so we can help them resume doing things right and help them learn to do it better and longer. And that creates a totally different platform for helpfulness. In addition, strengths are not the opposite of challenges. Strengths and challenges always go hand in hand. The more challenges you have, the more strength it's required for you to just get through the day. So on every day, even when people are struggling and they're not doing their best, they're using enormous strength for each and every issue. If someone is taking their medicine half the time, do we say that person is med non-compliant? Or do we say, amazingly, even though they don't like the meds and it gives them all the side effects, they're managing to take it half the time? And that second strength-based approach is a much more effective strategy for partnering with people and helping them make progress. Now, inside the service partnership, we work with people with all their issues in small steps over time to achieve success. And we have to remember that this is slow going. We're not going to fix people in 3 weeks or 6 weeks or 6 months. This is a lifelong journey. in the best research on quote unquote integrated treatment for people with serious mental health conditions like serious psychotic disorders who have serious substance use, who when we meet them are not terribly interested in anything that we're selling. Best treatment, it takes 3 to 4 years for half the people to get sober. And during that time, most of the rest are still making progress, even though they may still be using. And we get impatient often if people aren't sober in 3 to 4 weeks. And the more impatient we get, the worse everybody feels, and we bounce people all over the place, which costs more and everybody does worse. So settling into this partnership and building instructions around how to do it and how to measure progress is critically important. What's the third principle? All people with co-occurring issues are not the same. Well, this doesn't sound all that surprising. We kind of know that. But at the moment you know that, you suddenly realize that we still operate as if it's not true. So I constantly get requests from people all over, because I'm an expert, I'm looking for a co-occurring program for my nephew. Like there's one program for anybody who's co-occurring, and I should just know what it is. And that's where the problem lies. Like you may be in our agency, we're all cool because we have a co-occurring group. And we have 500 clients and 8 people go to the co-occurring group. How many of them are co-occurring in your whole client base? Well, 700. Okay, so you have 5 in one group, and whatever that is, that's great. But what about everybody else? So co-occurring means any combination of any mental health issue and any substance issue. Well, there's all kinds of mental health issues. There are differences in severity and chronicity and associated impairment and acuity. There's differences in, same thing for substance use issues. And so there's any possible combination, people are different. And then in addition to that, people have different preferences about what they think is important. So across an entire system, like in your region, there are lots of different organizations that are working on this. And every organization has different programs, and the programs have different jobs. Inside what the program does, there are co-occurring people that naturally come in, and that program has to be a co-occurring program for those people inside what they're coming for. Are they coming for mental health help? Are they coming for substance help? Are they coming because they need housing? What is it they're showing up and asking for? And then how do we most help them inside the door where they show up? Inside, everybody program has a job to be helpful to its people. And part of everybody's job in this project is to be helpful to their partners as well. Every program partners with other programs to help each other, not through referring people back and forth primarily, but through consultation and in-reach. It's easier for staff to move around so the clients don't have to. Okay, because it's really hard for clients to make even one connection, let alone when we send them to 2 or 3 different places and they're supposed to try to figure out how to put it all together. So within this, we start thinking about the different jobs of each program, how each program does that well, and how all the programs help each other, so more people get what they need in a single door. We also think inside our individual work that all co-occurring people are not the same. And what that means is for any person that you have that has more than one issue, your job is not just to get to know the issue you're familiar with, but to get to know the other issue too. How severe is it? How long-standing is it? Okay, and designing your help to match the level of the issue. There's the 4-quadrant model is a simple high, 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 low, low, high, low, low kind of thing. But even more sophisticated, what we're doing now is we're saying there's a difference between, in the world of substance use, for example, not everybody uses substances, but everybody makes substance decisions. Many people make substance decisions that are healthy. Some people make substance decisions that are unhealthy. We call that substance misuse. Some people start to develop more severe substance use patterns that are often called substance use disorders or addiction. And in that context, what starts to happen is the person is not only making bad choices, they're starting to lose control, even when they want to be in control. And there's a whole range of severity when there's a little bit of lack of control, all the way to people being really unable at any level to control themselves, even when the harm they're facing is enormous. Okay. And we recognize that for people who've experienced the more severe patterns, even when they try to stop, their brain is literally on the other team. Their brain is programmed to keep wanting to get high, even when another part of them is consciously trying not. So they need a lot of help to gang up with them against their own brain to be successful. For mental health, there's the same similar thing. Everybody's got feelings. Everybody has painful feelings. Most people figure out how to manage their painful feelings with some reasonable degree of success, but almost everybody has some maladaptive thing they do to manage their feelings that probably they shouldn't do, like eating lots of chocolate when you're, anxious or whatever. Or it could be using substances, to manage your feelings, and that's a piece of misuse and maladaptive feeling management. But some people not only have mismanaged difficult feelings, they may actually go on to start having mental illnesses, which also, your brain is on the other team. And it's not just a set of feelings, it's a whole syndrome and events, and you need help to gang up with you against your own brain to be successful. And there's mild and moderate illnesses that many people in the general population have, and many people with substance use issues have. And then there are more severe illnesses that are more severe and more, even at their best, they're continuing symptoms and associated disabilities and the like. So knowing where your person fits in the level of severity of this and paying attention to how you help them with the thing they actually are experiencing, not by reading it in a book, but by listening to them empathically, so you're a good partner, and learning with them about what's recommended, that helps you to be really successful, also with a different range of individuals that are showing up at your door. What's the next principle? Well, we often talk, which is the primary problem, which is the real problem, which is the underlying problem. And those are all like traps. When people have multiple issues, we think each one of their issues, conditions, disorders, diagnoses is primary because they're all important. They may not be equally severe. They may not be equally, on the first or second list for the person. But every issue is something that in the person's journey toward their happy life that needs attention. And so the best practice approach for people with multiple issues or conditions is the best intervention for each condition at the same time. Okay, and yes, there are interactions and overlaps and all of that, but if we go down that path, we just get confused. The simplest thing for our clients, just as it is for us, is here's the issue, what's the best thing for me to do for that issue? And further, to break it into small steps. So it's not what's the best thing for me to do for this issue from now and forever, but what's the next best thing for me to do for this issue this week? And for this other issue this week, I've got 4 or 5 different things I'm dealing with. What's the best baby step forward? And if that starts feeling too complicated for you, then guaranteed it's too complicated for the person you're trying to help. So make it simpler, make it smaller in smaller steps. And these conditions, as it says on the slide, for diagnoses, as it were, there are often medications like medical diagnosis, diabetes, heart disease, schizophrenia, bipolar disorder, major depression. And now we have medications for, opioid use issues and alcohol. But there are also, for all things, there are also psychosocial interventions. Medications alone rarely is going to do the job. And then there are lots of conditions people experience that are really important, that are not illnesses at all, not diagnoses at all, but they're psychosocial issues, cultural, linguistic barriers, immigration barriers, homelessness, housing, and the whole list. And the people we work with have these. They have a list of primary issues, and everybody needs help to find their next step. And we need to be great partners helping them to do this. And it helps us a lot when our service planning tools help us to structure things, to identify those next steps, and allow us to slow down so we stay connected to that person and help them make progress with each issue a step at a time. Okay. And there's often going to be a mismatch between the tools that we use and the requirements that we're trying to meet and what our clients actually need. So how do we figure out the right next step? Well, that brings us to principle 5. Because even though people have many issues, they're not necessarily always in the same place for what they want to do about these issues. Now, we tend to always be in the action phase for everything. As soon as we know it's there, we want to fix it. But that's not how it is for most people, including us. And we have a language that we use. It's a little jargony. We use this language to talk about the process by which people move through change and addressing different issues. We call it stages of change. And there's a language that talks about things like motivational interviewing and matching interventions to stage matched interventions, stage matched outcomes. The key to doing this for people with complexity is the recognition that when somebody says, what stage of change is your client in? The correct answer is always for which issue. Because stage of change is issue specific, not person specific. And most people have lots of issues, including us, and are likely to be in different stages for each. I want to work on my mental health. I don't want to deal with substances. I want to work on this substance, but not that substance. I want to work on substances, but don't tell me I have a mental health problem. I don't want any of those things. All I need is a place to live. My only problem is a judge problem. My only problem is a girlfriend problem, whatever. And so people come in the door, and part of the door they choose often is based on what's most important to them. And they bring their other issues along with them in whatever stage of change they are. So a key to successful partnership in the integrated service delivery business is creating a good stage-matched partnership for each condition. And in order to do that, we need the structure to do that in our assessments and our service plans and our work. And we need to learn how not only to do stage-matched interventions, but to recognize that moving through stages slowly is a big success. So if we're not satisfied until we get to maintenance, we're going to be frustrated and we're constantly thinking the person is failing. But if we've done brilliant work over a period of months for one issue, to have that person who's connected to us about something move from pre-contemplation to contemplation about something else, good job. That's a success. That's a round of applause. That's a piece of strength. So this helps us to organize progress so it really works. So we teach 6 stages of change and little sentence prompts attached to each. And we encourage people to make this simple, but practice it so you get better and better at it by building it into your routine use of tools and language and supervision and so forth. Pre-contemplation, you may think this is an issue, but I don't. Even if I do, I don't want to deal with it, so don't bug me. And the interventions or motivational strategies, the outcome is contemplation, not moving from pre-contemplation to maintenance, but pre-contemplation to contemplation, moving from don't bug me to I'm willing to talk with you and think with you about this issue and consider whether I should do anything differently, but I have no interest in changing, at least not now. And the outcome of contemplation, which can go on for quite a while, is preparation, not contemplation moving to complete maintenance, but I'm ready to start changing and I need some help to know where to begin, which could be a baby step of change. The smaller the step, the easier to get started to move from contemplation to down the action path. And after preparation, people go, again, early action. I'm doing some things, but not everything. I've not set the perfect goal, but I've set a partial goal. I've begun to make some changes, need some help to continue, but I'm not committed to maintenance or following all your recommendations. So we're partnering with people. I don't want to quit smoking, I'm cut down. I don't want to quit drinking, I've cut down. I don't want to take medicine every day, but I'll take it a couple of times a week. Okay, whatever. And let's see how that works. Let's see if you need to, is this helping you achieve your goals? How do we make better decisions for you about what's going to work and what's not going to work in this process of your figuring out how to move forward? And after a while, a lot of people get to late action where they're saying, oh my God, I really do need to get a handle on this issue. I need to do everything I can. I'm trying, but I'm not doing as well as I want. And they need more skills and they need more tools to know how to do it better. Just because you say you want to stop using substances, particularly when you have co-occurring mental health issues and other challenges, doesn't mean it's just willpower. You need a whole lot of tools, especially when your brain's on the other team. So, and people need help to figure out how to learn those tools. So that's what late action is. And once people get into maintenance for anything, then immediately the world starts tossing challenges in their path that make it, that create the risk that people are going to go backwards. So we have to help people prepare, to meet those challenges and develop new sets of skills and tools along the way. So for each issue, for each stage, there's a baby step forward. And this provides a structure to know how to be in an effective partnership with anybody, help them tie what they're doing to their hopes and their strengths, leverage the things they're most interested in to help them address issues that are harder for them in earlier stages, and make progress slowly over time. And then finally, the last principle, when we're actually working with people to change, what are we doing? What actually helps? And this is something else that's been very difficult for folks, because we tend to measure success around things like the person is following all the rules, they're attending all their appointments, they're doing everything we tell them to do. And just being compliant is not the thing that gets you out the other end. Everybody who has any issue, including us, has to learn the skills they need to succeed. And our job is, once people start to make change, we have to not just tell them what to do, we have to help them learn how to be successful. And that often involves very small steps of practical learning, not just giving people lectures, but role playing, rehearsal, skill practice over and over again, teaching people self-management skills, things they do by themselves, asking for help skills from professionals, family members, friends, peers, asking for help skills if they're on medication, how do they work with a prescriber? They're not on, how do they take medication properly when they're on their own? And then all the psychosocial skills and helps that people need. And the structured learning needs to create a balance of support and challenge that's right for the person. So we support the learning in small steps and big rounds of applause for each step of progress, which is, the fancy name is positive contingent learning, because reward is a much more effective way of helping people to learn, change, and grow than punishment. Even though so many of the rules and requirements that are built into our programs and our system are punishment-based, where we give people expectations and find negative consequences if they mess up, which doesn't work. And thinking about how to redesign the way we work with people so it's skill-based and reward-based is also something that's within the realm of what we do, whether we do individual work or group work or both. But it requires some purposeful thinking to help us understand what is it we're really trying to help people learn while they're with us, and how do we actually use our time with them to help them practice the skills they need. So the end result is that we want to create a system where no matter where people show up with co-occurring needs, they experience welcoming and they experience the opportunity to get connected to empathic, hopeful, continuous, integrated recovery and support partnerships, in which all the partnerships are organized to address multiple primary issues in small steps, providing adequately supported, adequately rewarded, strength-based, skill-based, stage-matched, community-based learning for each issue, so that each program is supported by all the other programs through consultation and in-reach to help the people that are most comfortable in their door make step-by-step progress on all their issues to achieve the goal of a happy, meaningful life, which they're all capable of achieving and deserve to get. And so what this is about, this is what this is about for this. And there's a lot to it, a lot of opportunities for everybody to look at their own stuff and say, we know we're doing cool things, but really, what have we built into our policy and procedures that support this for everybody, so that we're really consistently applying stuff that works, that's welcoming, hopeful, integrated, strength-based, and we're not doing stuff that doesn't work, that's hope taking away, that's deficit-based, that's punitive and negative, that's not helpful. So in this, every program is a co-occurring program. whatever your program license and regulation, whatever your staffing, whatever your funding, whatever your mission and resource. Every person providing care starts to become co-occurring competent because those are the people you're helping inside your job and level of training. Service delivery is supported according to the principles and interventions by practice supports that make it easier for people to learn as they do and do their job successfully. It's a 12-step process for each agency to follow for itself. And regardless of whatever anybody else does, that agency can make lots of progress in this context just to create a better environment for its staff and better results for its clients. Everybody's in the serenity prayer of change, which means let's work on what our power to do is and not look over our shoulder and try to change the people across the room. Our own inspiration, experience, strength, and hope is the biggest thing that helps other people to move forward. Avoid the training trap. Don't think we train people. Training alone is the evidence-based worst practice for transformation. Because training goes in one ear and out the other if it's not supported by the right practice instructions, policies, procedures, support, supervision, ongoing reinforcement inside our work. And we want to move away from the idea that everybody with co-occurring issues gets connected to multiple people. So our big goal is to refer people all over the map. Our big goal is to bring services to people. Okay, so wherever the person is most comfortably and naturally engaged, let's wrap services around that person in the most efficient and effective way we can. So we welcome you into this process. There's lots more to learn, and we're going to have a lot of fun doing this over the course of the next year. But thank you for listening. And if this gets you excited and you think, I want to be part of the change in my agency, raise your hand, contact your project leader, contact Dell, and say, I want to be a change agent. Or if you like somebody next to you and you think they'll be great, but they're shy, nominate them. What the heck? We're welcoming lots of cool change agents into this process. So thank you all for listening. I hope this is a helpful way to get you all started in understanding what this is about. And we look forward to a great journey together.